So let's discuss chapter 18 in Katzung's board reviews. This chapter is all about prostaglandins and other eicosanoids. So first of all, what are eicosanoids? Eicosa in organic chemistry refers to the number 20. So the eicosanoids are an important group of endogenous fatty acid autocoids. So oids is derived from autocoids, okay? So they are an important group of endogenous fatty acid autocoids that are synthesized from arachidonic acid, a 20 carbon fatty acid lipid in cell membrane. So if you remember organic chemistry that you studied in class 11 and class 12, you can remember that arachidonic acid is unsaturated, whereas arachidic acid is saturated. So families of eicosanoids of clinical importance include the straight chain derivatives. So you have the leukotrienes, and the cyclic derivatives you have prostacyclin, prostaglandin, and thromboxane. So that's why the classification is pretty straightforward. So you have eicosanoids which are divided into straight chain derivatives called leukotrienes, and then prostaglandins and prostacyclins and thromboxanes, which are your cyclic derivatives. Coming to the antagonists of eicosanoids, you have leukotriene antagonists such as leucast, so monteleucast, zafirleucast, so leu is there, okay, and then zileuton, leu, okay, and then you have prostaglandin antagonists such as corticosteroids and non-steroidal anti-inflammatory drugs, or NSAIDs or NSAIDs, okay, you can call them however you want to. So coming to the eicosanoid agonists and their classification, the principal eicosanoid subgroups are the leukotrienes and a group of cyclic molecules including prostaglandins, prostacyclins, and thromboxane. The leukotrienes retain the straight chain configuration of the parent arachidonic acid. Prostacyclin, thromboxane, and other members of the prostaglandin group are cyclized derivatives of arachidonic acid. There are several series for most of the principal subgroups based on different substituents indicated by letters A, B, etc., and different numbers of double bonds indicated by a subscript number in the molecule. Coming to the synthesis of eicosanoid agonists, active eicosanoids are synthesized in response to a wide variety of stimuli. Okay, there can be physical injuries, there can be immune reactions that activate phospholipases in the cell membrane or cytoplasm, and arachidonic is then released from membrane phospholipids. Okay, arachidonic acid is a tetraenoic. So tetra means 4, ene refers to double bond, okay, in organic chemistry. So tetraenoic refers to 4 double bonds containing fatty acid, and then it is released from membrane phospholipids. So once again, what happens? So active eicosanoids are synthesized in response to a wide variety of stimuli. So whenever you have a stimulus such as physical injury or immune reaction, what these stimuli do is they activate phospholipases in the cell membrane or in the cytoplasm, and these phospholipases act on membrane phospholipids to release arachidonic acid. Okay, arachidonic acid is then metabolized by several different enzymes. The two most important are lipoxygenase LOX, which results in straight chain leukotrienes, and cyclooxygenase COX, which results in cyclization to prostacyclin, prostaglandins, or thromboxane. So the two major pathways for arachidonic acid to be converted into its derivatives are the lipoxygenase pathway, through which it is converted into its straight chain derivatives leukotrienes, and the cyclooxygenase pathway, through which it is converted into its cyclized derivatives such as thromboxane, prostacyclins, and prostaglandins. COX exists in at least two forms. COX1 is found in many tissues. The prostaglandins produced by COX1 appear to be important for a variety of normal physiological processes. In contrast, COX2 is found primarily in inflammatory cells. Okay, COX2 is found primarily in inflammatory cells. The products of its actions play a major role in tissue injury, for example, inflammation. In addition to these inflammatory functions, COX2 is also responsible for synthesis of prostacyclins and of prostaglandins important in normal renal function. Okay, so thromboxane is preferentially synthesized in platelets. Okay, if you remember last year's physiology, so you remember that thromboxane A2 especially is preferentially synthesized in the platelets, whereas prostacyclin is synthesized in the endothelial cells of blood vessels. Naturally occurring eicosanoids have very short half-lives, seconds to minutes, and are inactive when given orally. Coming to some high yield terms, so what is an abortifacient? So abortifacient is a drug used to cause or facilitate an abortion, abort. So for example, prostaglandin F2A. So F here is facient, okay. So F2 alpha, okay. So that is facient. So abortifacient. Then you have cyclooxygenase. So it is an enzyme that converts arachidonic acid to its cyclized derivatives prostaglandins and prostaglandins, so PGG and PGH. The precursors of the prostaglandins including PGE, PGF process cyclin and thromboxane, so PGG and PGH. Next, what is dysmenorrhea? So painful uterine cramping caused by prostaglandins released during menstruation. Then great vessel transposition is a congenital anomaly in which the pulmonary artery exists from the left ventricle and the aorta from the right ventricle, okay. Normally, if this is your heart, okay, if these are the atria and these are the ventricle, see, this is your left ventricle, this is your right ventricle, okay, anatomically. So the aorta normally exits from the, or begins from the left ventricle, but in great vessel transposition, the aorta begins from the right ventricle, okay, and the pulmonary artery which should begin from the right ventricle, it begins from the left ventricle, okay. In what? In great vessel transposition, opposite happens. So this anomaly is incompatible with life after birth unless a large patent ductus or ventricular septal defect is present. So lipoxygenase is an enzyme that converts arachidonic acid to leukotriene precursors. So NSAIDs are non-steroidal anti-inflammatory drugs, for example aspirin, ibuprofen and celecoxib. So NSAIDs are cyclooxygenase inhibitors. You need to remember this. NSAIDs are cyclooxygenase inhibitors. So oxytocin is a substance that causes uterine contraction. It mimics oxytocin, which contracts the uterine smooth muscle. And then patent ductus arteriosus, PDA. So it is abnormal persistence after birth of the shunt between the pulmonary artery and the aorta, and it is normal in the fetus. Okay. So phospholipase A2 is an enzyme in the cell membrane that generates arachidonic acid from membrane lipids. So slow reacting substance of anaphylaxis, SRSA. So it is a material originally identified by bioassay from tissues of animals in anaphylactic shock, now recognized as a mixture of leukotrienes, especially LTC4 and LTD4. Leukotriene C4 and D4. So replacement of tetraenoic fatty acids in the diet with trienoic or pentaenoic precursors results in the synthesis of much less active prostaglandins and leukotriene products. Thus, dietary therapy with fatty oils from plant or cold water fish sources can be useful in conditions involving pathogenic levels of eicosanoids. Coming to the mechanism of action, so the most eicosanoid effects are brought out by activation of cell surface receptors that are coupled by the GS protein to adenylyl cyclase, producing cyclic adenosine monophosphate or CAMP, or by the GQ protein coupled to the phosphoinositol cascade, producing IP3 and DAG as second messengers. So one thing we need to remember, GS coupled protein, so it increases cyclic AMP or CAMP, whereas GQ coupled protein, it increases IP3 and DAG, diacylglycerol. So 4 receptors for PGE have been identified, so EP1 through EP4. 2 PGF receptors are denoted as FPA and FPB. PGI2 effects are mediated mainly by the IP receptor, IP receptor. Thromboxane TXA2 acts via TP alpha and TP beta receptors. Thromboxane A2, we talked about this extensively while studying platelet physiology. So TXA2 acts via TP alpha and TP beta receptors. 2 leukotriene B4 receptors are denoted BLT1 and BLT2. The major LTC4 receptor is called cis-LT2, while the LTD4 receptor is denoted as cis-LT1. Okay. So coming to the synthesis of eicosanoid autocoids, so arachidonic acid is released from membrane lipids, okay, by phospholipase A2 whenever there is a physical injury or immune response that acts as a stimulus to cause the release, and then it is converted into straight chain derivatives or leukotrienes through the lipoxygenase pathway, or it is converted into cyclase derivatives by cyclooxygenase. Okay, so into prostacyclins, prostaglandins, and thromboxanes. NSAIDs are cyclooxygenase inhibitors. Okay, Zileuton is a lipoxygenase inhibitor. Next, because many of these products are pathogenic, drugs that inhibit synthesis or prevent the actions of the products are clinically useful. So coming to the effects of some important eicosanoids, a vast array of effects is produced in smooth muscle, platelets, the central nervous system, and other tissues. Some of the most important effects are summarized in this table right here. So coming to the major receptors for PGE2, it is EP124. Okay, for PGF2 alpha you have FPA and B. PGI2 IP receptors. TXA2 you have TP alpha and TP beta. LTB4 you have BLT1 and 2. We discussed all this again. LTC4 cis-LT2 and LTD4 cis-LT1. Okay, D is 1 and C is 2. Okay, you can remember this. Now, the coupling proteins, so PGE2 is GS and GQ mediated, PGF2 alpha is GQ mediated, I2 is again S mediated, I2 is S mediated, okay, F, QF, okay, QF, okay, and then thromboxane A2 is again 2Q, the rhyming is same, right, 2Q, okay, the rhyming is same, you can remember it like that, or Q, you can remember the letter itself instead of the expanded word. And then LTB4 is also GQ mediated, LTC4 is also GQ mediated, LTD4 is also GQ or GI mediated. So you can remember it through this manner. Mostly all 2s are GQ mediated, so E2 and F2, and then thromboxane A2, and multiples of 2 are all again GQ mediated, whereas the only difference is PGI2 is GS mediated, you can remember it like that. Okay, so coming to the vascular tone, PGE2 decreases vascular tone, okay, PGF2 alpha increases or decreases vascular tone, PGI2 decreases the vascular tone. Okay, if you increase the contraction, it decreases the vascular tone. So okay, if you are decreasing the tone, PGE2 dilates, PGF2 alpha increases or decreases, PGI2 is decreasing the tone, so it must constrict the vessels. Thromboxane A2 is increasing the vascular tone, I2 is decreasing the tone, so it must dilate the vessels. Thromboxane A2 is a vasoconstrictor, platelet adhesion and all that, so it constricts the vessels and increases the vascular tone. Okay, LTC4 again increases or decreases, D4 again increases or decreases. Coming to the bronchial tone, okay, so usually the trend you can see is that bronchial tone, it kind of there is a similar effect as that of vascular tone. So PGE2 decreases vascular tone as well as bronchial tone, and then PGF2 alpha increases the bronchial tone. E and F, you can remember it as they're antagonistic to each other. PGI2 again, it decreases the vascular tone and it decreases the bronchial tone. Okay, so it is dilating both vessels and the bronchi. And then TXA2, it is increasing the tone of both the vascularity and also the vasculature and also the bronchi. And then LTC4 and LTD4, they are greatly increasing the tone, that means they are greatly constricting the bronchioles. Okay, the uterine tone again, so PGE2 increases or decreases. So low concentrations cause contraction, PGE2, of the uterine muscles, and high concentrations cause relaxation. That is one thing you need to remember. PGF2 alpha greatly increases your uterine tone. Okay, F, we remember it as abortifacial. So it is aborting, means it should increase the contraction of the smooth muscles in the uterus, so it should increase the tone. Okay, and then PGI2 again, it is reducing the uterine tone. Thromboxane A2, it is increasing every tone, and the rest are so platelet aggregation, it is greatly increased in thromboxane A2 action and then decreased in PGI2. leukocyte chemotaxis is greatly increased by LTB4, LTC4 and LTD4, but mainly by LTB4. So eicosanoids are most directly involved in pathological processes include prostaglandin F2 alpha, thromboxane A2 and the leukotrienes LTC4 and LTD4. So LTC4 and D4 are components of an important mediator of bronchoconstriction and shock, a slow reacting substance of anaphylaxis. Okay. So leukotriene B4 is a chemotactic factor important in inflammation. PGE2 and prostacyclin may act as endogenous vasodilators. E1 and its derivatives have significant protective effects on the gastric mucosa. The mechanism may involve increased secretion of bicarbonate and mucus, decreased acid secretion, or both. PGE1 and PGE2 relax vascular and other smooth muscles. So PGE2 appears to be the natural vasodilator that maintains patency of the ductus arteriosus during fetal development. So one, it is just protecting your gastric mucosa. Two is, having most of the mainstream effects. In the kidney, prostaglandins are important modulators of glomerular filtration and act on the afferent and efferent arterioles and mesangial cells. Suppression of prostaglandin production with non-steroidal anti-inflammatory drugs, cyclooxygenase inhibitors such as NSAIDs, can markedly reduce the efficacy of diuretic agents. So PGE2 and PGF2 alpha are released in large amounts from the endometrium during menstruation and can cause dysmenorrhea. So PGE2 appears to be involved in the physiological softening of the cervix at term. PGE2 and PGF2 alpha may play a physiological role in labor. So platelet aggregation is strongly activated by thromboxane. Topical PGF2 alpha reduces intraocular pressure, but it is not known whether this is also a physiological effect of endogenous PGF2 alpha. Coming to the clinical uses, so in obstetrics, PGE2 and PGF2 alpha cause contraction of the uterus. So PGF, again abortifacient, so it contracts the uterine smooth muscle. E2, it is responsible for softening the cervix at term. So PGE2 as dinoprostone is approved for use to soften the cervix at term before induction of labor with oxytocin. Both PGE2 and PGF2 alpha have been used as abortifacients in the second trimester of pregnancy. Although effective in inducing labor at term, they can produce more adverse effects such as NVD, nausea, vomiting, diarrhea than do other oxytocics such as oxytocin used for this application. The orally active PGE1 analog misoprostol has been used with the progesterone antagonist mifepristone RU486 as a highly effective and safe abortifacient combination. So misoprostol has been used for this purpose in combination with either methotrexate or mifepristone in the US. Misoprostol may cause diarrhea. So what is an active PGE1 analog? Misoprostol. Okay, miso is a common ingredient in MasterChef Australia, so you can remember it as 1. So miso caramel. Okay, you hear about them a lot. So miso 1. So misoprostol PGE1 analog. E for endomolshine, which is the network that telecasts MasterChef Australia. So PGE1, so endomolshine, they use miso a lot. So misoprostol. Coming to pediatrics, so PGE1 is given as an infusion to maintain patency of the ductus arteriosus in infants with transposition of the great vessels until surgical correction can be undertaken. Pulmonary hypertension and dialysis, prostacyclin PGI2 is approved for use as ipoprostenol in severe pulmonary hypertension and to prevent platelet aggregation in dialysis machines. Okay. Peptic ulcer associated with NSAID use. So misoprostol is approved in the US for prevention of peptic ulcers in patients who must take high doses of NSAIDs for arthritis and who have a history of ulcer associated with NSAID use. So if you are afraid that the person who is using chronic NSAIDs, so if you are afraid that he'll develop an ulcer, so you can use misoprostol. So again, what is misoprostol? Miso, okay, so E1 PGE1 analog. So urology, so PGE1 as alprostadil is used in the treatment of impotence by injection into the cavernosa or as a urethral suppository. Then in ophthalmology, so latanoprost, a PGF2 alpha derivative, is used extensively for topical treatment of glaucoma. So bimetoprost or travoprost and uniprostone are related drugs. These agents reduce intraocular pressure apparently by increasing the outflow of aqueous humor. So coming to eicosanoid antagonists, phospholipase A2 and cyclooxygenase can be inhibited by drugs, and some of these inhibitors are mainstays in the treatment of inflammation. So xylitol is a selective inhibitor of lipoxygenase. Some cyclooxygenase inhibitors also exert a mild inhibitory effect on lipoxygenase. So inhibitors of the receptors for the prostaglandins and the leukotrienes are being actively sought. So montelukast and zafirlukast, oral inhibitors at the cis-LT1, the LTD4 receptor, are currently available for the treatment of asthma. So one thing you need to remember is that xylitol, it acts at this level. It is a lipoxygenase inhibitor, whereas zafirlukast and montelukast prevent the action of leukotrienes on their receptors. Okay, this is where they act. So coming to corticosteroids. So as indicated in the figure, corticosteroids inhibit the production of arachidonic acid by phospholipases in the membrane. So this effect is mediated by intracellular steroid receptors that, when activated by an appropriate steroid, increase expression of specific proteins capable of inhibiting phospholipase. So steroids also inhibit the synthesis of COX-2 or cyclooxygenase 2. These effects are thought to be the major mechanisms of the important anti-inflammatory action of corticosteroids. NSAIDs. So aspirin and other non-steroidal anti-inflammatory drugs inhibit cyclooxygenase and the production of thromboxane, prostaglandins and prostacyclins. So NSAIDs are cyclooxygenase inhibitors. Most of the currently available NSAIDs, such as ibuprofen and naproxen, non-selectively inhibit both COX-1 and COX-2. In fact, many inhibit COX-1 somewhat more effectively than COX-2, the isoform thought to be responsible for the synthesis of inflammatory eicosanoids. So celecoxib is the most selective COX-2 inhibitor available in the US. Meloxicam is also slightly COX-2 selective. So celecoxib is COX-2 inhibitor, most selective COX-2 inhibitor. The highly COX-2 selective rofecoxib and valdecoxib, so COX, in the name itself you have COX, and if you add IB, that is if you are adding 2 letters, they are more slightly selective for COX-2. So COX inhibitors add COX, okay, add 2 letters for COX-2 selective inhibitors, so COXib, add 2 letters to COX, so COXib, so celecoxib, okay, and then rofecoxib and valdecoxib. Okay, so rofecoxib and valdecoxib were withdrawn from the US market because of reports of cardiovascular toxicity. Inhibition of cyclooxygenase by aspirin is irreversible, unlike the reversible inhibition produced by other NSAIDs. So aspirin allergy may result from diversion of arachidonic acid to the leukotriene pathway when the cyclooxygenase catalyzed prostaglandin pathway is blocked. The resulting increase in leukotriene synthesis causes the bronchoconstriction that is typical of aspirin allergy. For unknown reasons, this form of aspirin allergy is more common in persons with nasal polyps. The antiplatelet action of aspirin results from the fact that the drug's inhibition of thromboxane synthesis through the cyclooxygenase pathway inhibition is essentially permanent in platelets, so non-nucleated cells lack the machinery for new protein synthesis. Therefore, recovery of thromboxane production requires the generation of new platelets. In contrast, inhibition of prostaglandin synthesis in the vascular endothelium is temporary because these nucleated cells can synthesize new enzyme. So, inhibition of prostaglandin synthesis also results in important anti-inflammatory effects. Inhibition of synthesis of fever-inducing prostaglandins in the brain is responsible for the antipyretic action of NSAIDs. Closure of a patent ductus arteriosus in an otherwise normal infant can be accelerated with an NSAID such as indomethacin or ibuprofen. So in Guyton and Hall, you read about indomethacin as a drug being used in patent ductus arteriosus. So indomethacin. And leukotriene antagonists, as noted, an inhibitor of lipoxygenase, xylitol, and LTD4 and LTE4 receptor antagonists such as zafirlukast and montelukast. You cast these leukotriene antagonists at the receptor level. So zafirlukast and montelukast are available for clinical use. Currently, these agents are approved only for use in asthma. Okay, so that's it about this chapter. We've talked about all these things. Okay, one last time, if you really fear any ulcers that might occur because of chronic NSAID use, what do you need to do?